Hello, I wanted to go over last week's case study. First of all, I had asked you at a previous time to highlight the abnormals on the case study. Since not all the abnormals necessarily relate to the problem per se, I just want to make sure that you know that they're abnormal. So pretty much here we have the abnormal of a 1-week history of respiratory symptoms, upper respiratory symptoms. Now just be aware that a lot of people that do come in for pneumonia come in for a cough and they just say, I've had this really bad cough and I just can't shake it or whatever else, and it's not until you really listen to them that you're like, oh, well, this is not just a cough. So just because they say upper respiratory tract symptoms does not mean that they have a lower respiratory tract disorder. And just so that you're aware, a pneumonia is a lower respiratory tract disorder, not an upper. Okay? Some people put that it was an upper. Okay, she's been coughing up rusty colored sputum. Now that's important to note. And she has left-sided chest pain. A lot of people with pneumonia will complain of chest pain. All right? She had a coworker that was sick, which, might be important, not, but you definitely always want to know about sick contacts. And she's a smoker, which always is something we need to know about because, smoking increases the risk for so many things, right? And she's a little older. So we know her weight. Some people calculated her BMI, some people did not. And then we have her temperature, which is actually pretty high for an adult. For a kid, we wouldn't worry about, we'd worry, but we wouldn't get overly concerned. But, 102 for an adult is much higher. She is a little tachycardic. She's a little tachypnic. She is coughing, and we watch her, and we're looking at her. She's using accessory muscles to breathe. Now, I hope you all know what that means when I say that. That means you can kind of see their necks kind of pulling in, and they're just working a little hard to breathe, okay? So you notice they're using a little nasal flaring. They've got a little purulent nasal drainage. Their TMs are injected with light serous fluid. Okay, their throat's a little red, and they have a little increased lymph nodes. Cervical lymph nodes. Now their lung sounds, they're using accessory muscles to breathe. That means when you look at them, their little muscles above their neck are kind of working. When you look at them, they're pulling at their chest a little bit more. Now this can be harder to see, especially in someone that is a little overweight, which she's not. She's normal weight. But if you get someone that's a little overweight, you may miss this particular symptom, okay? She's splinting because of the pain. When you listen to her, she doesn't sound quite right. That left middle lobe area sounds a little different to you, but the other areas of her lungs are clear. That's important to note too, all right? With the bacterial stuff, you will hear like a particular area of the lung that has an issue. That's why if somebody comes in with coughing, you just can't listen to their upper lobes and be done. You have to listen to their entire lung, to all areas of the lung, okay? Remember, right, you have 3 lobes, left you have 2, but you got to, basically listen up the upper, middle, and lower part, and and also you need to listen on their back as well, okay? Otherwise, they don't have any organomegalia, they're warm, she's not cyanotic, there's no clubbing, which would be a long-term sign, right, not a short-term sign. She's oriented, she's got good reflexes, so there's nothing that we can see that looks like central nervous system going on. Now, in our particular office, we can get an ABG, which is not super common, right? And from what I've been told by people, these things hurt. So, when you get arterial stick there, it hurts, so just be aware of that. So it's something you want to do just kind of willy-nilly. Plus, it's kind of technically difficult because you can't let the blood clot at all, okay? So the pH is elevated, the CO2 is low, but her O2 is fine, okay? Then we look at her CBC. Her white cell counts are elevated, her neutrophils, segs, PMNs, there's a bunch of different names for the same thing here, are a little elevated. Lymphs, monos, eosinophils look fine. So I included here just a thing of normal labs so we can see, you know, her crit is fine for her age. It was 43, I believe. But her white cell count is elevated. So 15, anything above a 10, this particular one has an 11. Where is it? Yeah, 11 up here. But anything really above a 10, you kind of think, better think about that for a minute. Okay. Some people, there was a couple of people that got concerned about her eosinophils. So I did some reading about eosinophils related to that because I was like, you know, sometimes I'm wrong. So I look and I try and read and see. Some people had that eosinophils were related to viral infections. Well, that is not true. But I did notice that if you do, and there was quite a bit, that if you do see increased eosinophils, you really can't ignore them. You got to figure out what's going on there. Okay. But we mostly think about that with allergic kind of stuff going on. But it can be related to some sorts of cancer, so we just don't want to ignore that. Her LFTs are normal. Truthfully, I don't know why you get LFTs in this situation, but they did, and they're normal. Okay. Her X-ray shows a left mid to lower lobe consolidation. All right. So I got an X-ray here. Now this X-ray is not of a woman, but it's pretty good because this is the consolidation. This border here should be totally, you know, clear and crisp like this one is. Okay. But this is a consolidation right here. This is the kind of thing you'll usually see if you have a person with pneumonia coming in your office, right? You're not going to see the ones that are usually on the internet that are just like socked into here, because those people are pretty darn sick, although she could be a little bit sicker than this. But I wanted to show you a more subtle pneumonia here. So when we look at this, you want to look at, you never want to zero in on an X-ray. You want to look at the whole X-ray. You look at the bones. There's no fracture. You want to look at technique. It's a pretty good technique. You want to look at, other things. Here's the trachea. Here's the median bronchus going down here. Okay. You want to look just kind of around at the whole thing. You want to look over the liver. It should be solid. You shouldn't see anything here but the liver. This is the stomach bubble right here. This is the diaphragm. That's the diaphragm. And, just kind of look around. Don't get tunnel visioned on your x-rays because that can get you into trouble. Now this, I should have said technique was good. This technique is actually, this person is a little lordotic. In other words, the film is kind of going up this way to an angle because the ribs are kind of bent more down here, and the clavicle should be about the level of this top rib up here. And it's a little, it's not bad, but it's a little off. The other thing you want to, just take a look at, make sure there's, no foreign bodies in there, there's no fractures in the spinal column, that sort of thing, okay? But we do see this little bit of consolidation here, which is not normal, all right? So then talk about differentials. Well, I alluded to, and you should have gotten it, most of you did, the number one thing you're going to think about is a left lower lobe pneumonia. Now, even before we got this x-ray, we should have been thinking about that, right? Because of the symptoms of the fever and the cough and then our physical exam, all right? So we get an x-ray in lab work to prove or disprove what we're already thinking. We don't get it going fishing, right? Really, we need to have, what are we looking for with the x-ray? Well, in this case, we wanted to confirm that it in fact was a pneumonia going on. And then we wanted to, with the CBC, we wanted to see if there looked like there was looked like it was bacterial or viral. Now with the neutrophils, segs, PMMs, like I said, they're all the same thing. Those tend to increase with a bacterial infection. Lymphocytes tend to increase with a viral infection. as a general rule, okay? Like I said, I don't know why you got liver test on this one. But you should have a reason why, you know, if you're a preceptor, when you're going in and you say, well, I want to get a, you know, a CBC or a BMP or whatever else, and they go, why? You better have a reason why. If your X-ray or your CBC or your lab work is not going to change your diagnosis, then you really got to think long and hard. Do you want it or do you need it? Okay. If you're going to treat them the same regardless, then you may not want to get it. Okay. You might want to just treat them, wait and see if they're getting better, and then get it. For instance, somebody had that they would get a sputum culture on this person. Probably not. You would just treat this person right now. If they weren't getting better, or if they were sick enough to be in the hospital, then maybe. Then you would get it, but probably not on the outpatient kind of situation. And this is a person that, depending on how they looked, you may or may not put inpatient. This is somebody you could probably treat outpatient since they're oxygenating fine, but I would definitely bring them in the next day to take a look and, you know, make sure they won't get any worse for sure after I started treatment. All right, so anyways, they've got a good idea here with their positives, okay? Strep pneumococcal pneumonia is more than likely the cause, and that is from that rust-colored sputum. If you look that up, you'll see that that's one of the hallmarks for that particular disease. Okay. All right, so this part looks really good. The negatives are really, you know, you see they've got their pretty normal breath sounds. That would be unusual, right? And then the ear being injected, which is probably from that upper respiratory tract infection type process they were coming up with. But that wouldn't necessarily stick with this one, so I agree with that. Okay. Now, influenza. Now, this person actually put that this would be a negative, that these were going on, but I think they were a little confused, so that's why I wanted to bring it up here too. So the positives, influenza actually, you know, could be going on there, causing a cough, and influenza can lead to pneumonia. You know, which is one of the big problems with the flu. But I wanted to show you what an injected TM with light serous fluid looked like. So there's the fluid. You can see this little bubbly fluid back in there. That should be just kind of clear. There shouldn't be anything back there, okay? The eardrum is a little retracted, and we can see that because the bones are prominent here. When I think about a retracted eardrum, I think about like when you put like cellophane over something and put it in the microwave and it sucks up around everything. You know, you put a piece of chicken in there and it sucks up around your chicken. Well, that's what retracted does. So it's sucking up around these little bones in there, okay? And the retracted means that the eustachian tubes are probably plugged. And that's what's going on there. You got a little bit of fluid plugging the eustachian tubes, probably got a little bit of edema of the eustachian tubes related to upper airway and tract infection. Okay? So that definitely could be the problem going on here. Now the negatives to this particular one, or this being the only issue, is the other things that look more like pneumonia. Okay? Acute sinusitis could be, but the negatives here again are the things that look like pneumonia. Now, when we look at the positive and negatives, now this person did a really good job. The positives are what this patient has that go with the diagnosis. The negatives are what this patient has or does not have that goes with the diagnosis. Okay? So you could tell me what you would have and what you wouldn't have with a particular diagnosis, but we really want to relate it back to our case study. All right? And then viral pneumonia could be, but the big thing here is the x-ray. All right? And then people with, and then the breath sounds too, because if you'll hear viral pneumonia kind of everywhere, you won't just hear it in one area of the lung. So that even just on physical exam, you're going to know that bit. And then bronchitis. Once again, you shouldn't see anything. Bronchitis is an inflammation of the bronchi, so it doesn't get down into the actual lungs, okay? Then the biggest thing here was you had a respiratory alkalosis. Several people asked me if we knew what the bicarb level was. It'd be nice to know maybe, but it's not going to help you because the bicarb is going to change when the person starts to compensate. All right? So this person is not compensating, and the reason we know they're not compensated or compensated, they probably are compensating, they're not compensated is because the pH is off. For them to be compensated, the pH has to be in the normal range or close to the normal range. Now, of course, when people are definitely going into failure or it's a long-term situation where they're really not doing well, and these people are probably not going to be in your office, their pHs may be on the lower or higher end of the normal range, and their bicarb, and they may be compensating, but that's a little bit, they've kind of like gotten sick, compensated, now they're kind of deteriorating, and they can't continue to compensate for it. Does that make sense? So you may see a situation like that, but probably not in your office. All right. So anyways, I thought this was a good review. I think most of you did a good job. Hopefully this was a big learning event. I really want to, several of you put down lung cancer too. Anytime you do have an x-ray that has a patchy infiltrate, even like this, in an older person that's smoking, you better check another chest x-ray in a month to 2 months. Now you got to wait a while because the chest x-ray lags behind clinical to change, and you want to make sure that's cleared so that that little pneumonia wasn't hiding some cancer. Okay, so you definitely want to recheck an x-ray on someone older and make sure you document that you're going to do it, because if they don't show up to get it done, and then 2 years later or a year later they come down sick and they go, wait a minute, why didn't you pick this up? You can show that you did due diligence. Okay, anyways, thanks.